Good morning, everybody, and I hope all of you had tea. And keeping fingers crossed that we have enough people in the room to hear us. But I'm very happy to see Dr. Muni Raju in the room, advisor Niti Ayog. I think very key people I hear already, those who need to hear to us. Um, Now, may I like to just very quickly invite my panelists. We have Dr. Mohammad Asil here. Minakshi Balasudram, my friend, is here. Now, may I invite Mr. B. Santosh Khanna on the stage. May I also invite Mohan Shankaran Shivaprakash from IIT Madras. While they all join on the stage, I'll just quickly introduce each one of them, though none of them need any introduction. I'll start with my friend Minakshi. Minakshi is a founder member of Equals. Equals is a non-profit organization. It's known as Equal Center for Promotion of Social Justice. An expert in the field of disability, somebody who we all come to when to understand budgeting, cost implication, intricacies and intersectionality of disability, particularly when it comes to policy, and somebody who's at a global level, somebody who have known for years, and she has this special ability to question anybody, be it her husband, her friends, colleagues, superiors, the government, anyone. So I think a great person to have on the same panel. I think this is the first time I'm moderating a panel with Meenakshi. Yes. So I'm going to question her. So great. Um, Mohammad Ashil, who is with the WHO, currently it holds the position of a country focal point on National Professional Officer for Injury, Disabilities, Rehabilitation, and Accessibility. Previously has worked as the ED of National Institute of Physical and Medicine Rehabilitation and Director of the State Initiative on Disability and Executive Director of Kerala Social Security Mission. A lot of experience with how the government works. I think very critical to have him on this panel. Mr. B.S. Santosh is a dedicated professional and serving as a lecturer of Department of Therapeutic and specializing in physiotherapy. Is got an illustrious educational background. If I may mention a few, he's an MPT, Master in Science, DSM, DSPT, and to name a few. With remarkable 12 years of experience in the field, I think coming from NIPNED, he will add a very interesting angle on issues of AT and people with multiple disability. Mohan Shankaran Shivaprakasam, Professor of Department of Electrical Engineering at IIT Madras, holds the position of Head of Healthcare Technology Innovation Center. And I think healthcare and disability is now is being looked at from the same perspective and from the same prism to some extent. So I think all of you is I think going to make a very interesting one, and it will be difficult for me to moderate and keep time. I think 12:30 we need to stop, and will be followed with some few questions. I will, though I didn't plan of this panel, and Meenakshi was asking, or even Asil was asking, what are the questions? And while coming to Empower today, I thought this is. Empower created this platform, and from last year I have been coming here, and Professor Jhunjhunwala's interaction with us about influencing policy of, making ATA affordable for people with disability, and we are very closely associated with his team. I work very closely with Akila, and we have some interaction going on with the government for influencing certain policies. But, looking at India being the most populous country in the world, it also means that we have the highest population of disabled people with us. And there's a huge, rural and urban divide. The wheelchair I sit on is an imported one. And my good friend from Neo Motion, Siddharth, keeps taunting me each time he sees me that why you are buying such an expensive wheelchair each time, and so on. And affordability, I think, is a major, major issue for everybody. No matter which strata of economic strata you come from. So my question to each one of you, the first one, we're looking at the population of disabled people in the world. And if you look at India, which is, if you look at, the report of UNFP, where, by 2050, 60 plus population of India is going to be, very high, 15% or so. And 80 would something would not be limited to people with disability. It's something which will be a way of life. So where are we? What is that we need to do? And if I start with you, Meenakshi, yes.
Arman, I hope you will compensate the time for this. So actually, my thing is, where do we start? Say, assistive technology and assistive devices and technology. We all know that the diversity of persons with disabilities need one or more assistive devices for participating in the day-to-day life, as you're saying, Arman. And it varies, and its requirement is intense among population with high support requirements. And it allows us to enjoy our socio-economic and cultural rights. It's a base, it's a precondition for our dignity and also for our participation. With all this other background, we find that, as you said, it is not accessible, firstly. I'm currently looking out for a cool wheelchair to suit my needs. I mean, that was the conversation I had before coming here. Apart from health, managing our health and habilitation requirement, this is kind of the background that we come from. It allows us to participate in the community. But as far as the extent of how much it is available is, one of the major scheme that we have is the ADIP by the Union Government of India. And that is the major cost, that the government has put in. So actually what I was talking to you is about, it is about around 235 to 245 crores every year, which the Union Government of India puts in for the entire population of the country. And as you rightly said, there is a growing population and there is a growing need. And it is not that we need one kind of assistive device. It's kind of multiple device. You can see I'm using a caliper, I'm using a crutch, and I'm using a wheelchair. It varies depending on the situation. And everything is important for me to participate. This is the need that we are talking about. And as per the World Report on Assistive Device recently published by UNICEF, it is about only 3% of the population who need assistive device in the low and middle income country have access, from children's perspective, basically, have access to one. Leave the quality of the device. And as far as ADIP program is concerned, which is the largest program, in 2021, we have a problem with data disaggregated, but still in 2021 alone, they have successfully reached out to 81,000 people in India, the whole of India. 2021, we all understand it's COVID and all that, there has been but still it's not very huge. If you look at across states, complementarity between union and states, only 14 out of so many states and union territories in our country have their own specific program. And which is kind of put together, is in the current year, it's only 150 crores, all the 14 states. So the crores may sound big, but when you look at the scale, when you look at per capita, when you look at the overall requirement, actually on the specific allocation to persons with disabilities is only 0.006% of the GDP, of which assistive device, which is a major driver, second major driver of cost to the family of persons with disabilities, the government's contribution is around, it doesn't figure in the GDP comparison, but if you look at the overall total expenditure, it could be around 0.01% of the total, or 1% of the total specific allocation for persons with disabilities. This is what we are talking about. And I will come back to you in the next round on the design level issues if there is a question on that.
Yeah, Professor.
Yeah, you want me to talk about anything specific, or you want to ask a question?
The same question I would, what's your thought on it? And if you could add, if you look at India's situation, if you look at, I would say it's 100 million disabled people in India, if not more.
What did you say, sorry?
At least 100 million disabled
100
people
million,
in India,
yeah.
if not more. And if you look at the diversity of that, the urban-rural divide, and the affordability. And I would also put a challenge here on quality. The game is not on distribution and the number. What is the quality of it and the affordability for the last mile person? Your thoughts?
So it's very interesting. You look at the numbers, good that you said the 100 million. At any given time, around 100 million people need healthcare. Classic healthcare sense. What we call a 1% market, right? So typically, it's easy to understand. In a class, usually one guy is absent. So that's a typical, and even beds and hospitals, if you do the calculation, it's always this 1%. Right? The reason why I'm saying that, you look at healthcare market today is around, healthcare spending in India is around $100 billion. Maybe it is 80, maybe it's 120 because dollar keeps varying. The reason I'm using dollars is easy for you to calculate also. We'll come back to the crores. So it's about $100 per person is the healthcare spending in India. Just keep that in your mind, just park it. Average, we're talking about average. The government spending in healthcare is around 30% of overall healthcare. Of course, land doesn't get figured into that, but we can ignore land for a moment because once you bring in land cost, it actually becomes. So that's why private companies always keep complaining that actually land cost is very high. But we'll park that for a while. The medical devices spending out of this 100 billion is somewhere around 6 to 7 billion, which is around 50 to 80,000 crores. 60 maybe. Inflation has gone up last 2 years. Now, you ask yourself, right, the affordability and accessibility problems are there in medical devices. So what do we do if it is not available itself? Then we import it. There's a technology denial, not denial meaning technology unavailability, because we don't own the technology, we import. Or we actually make an indigenous product where it's possible. Right? Now, the reason healthcare affordability has become quite better, it's still not, but it's actually more of a financial problem, not so much of a technology denial problem or availability problem. The reason is, it is driven not only by a rights approach. Right? There is a right and there is a base. That's where the public health care spending and so on. But it has also has a strong business around it. Right? And this is very counterintuitive, right? You would think that, how do you solve an accessibility problem? Government should spend. That's not possible. No? The entire Ayushman Bharat budget of India, I've not looked it up recently, it's around 10,000 crores. That's the Ayushman Bharat insurance, of course. That's the insurance you have to understand. But that's a real spending. So, and we spoke about in the last Empower also, I was actually moderating the panel, it's very interesting. The key thing which all of us should reflect and should drive towards is you should not get stuck in the rights-based and the handout approach. Handout in a very bad way, but you know what I meant, which is you cannot go back to the government and say, add 2 zeros. They will take that meeting and then they will say, well, I don't have the budget. Okay? What you should do is you should demand government policies and create a larger enterprise ecosystem around it, right? So that people come and serve these problems, right? And find value both for them. And remember, the moment you have an enterprise ecosystem, quality automatically goes up. Neomotion cannot make low quality products because they're going to be compared and they're going to be competed from whether it's import, export, doesn't matter, right? They're going to be competed against. So quality can only be solved if there is a market-driven competition. Number one, I mean, you can keep arguing about this forever, but the answer is very clear. You look at your mobile phones. If the government was running this, we have all lived in BSNL era. So let's not now debate that part here. Now I'll get one more level deeper. But there is a fundamental difference also between healthcare and this. Now let's go back to that, right? Here, the economic disadvantage of people with disabilities is disproportionately higher compared to healthcare. Right? So no, that's a very, this is actually, it's a repeat of what we discussed in the Empower, right? So typically you will look at healthcare, about 30% of the people at any given time, you look at 100 million people seeking healthcare today in India, as we are talking today. Today there'll be 100 million people either at the hospital or the OT. You will find 30% are quite distressed. Distress meaning literally are at a distress. Right? Here, my feeling is that number is probably much, much higher. Probably 60, I don't know what it is. Right? Much higher, definitely. It's double. So you need, but that doesn't mean that you actually abandon this approach of quality and affordability. You look at ways how that additional 30%, right, can be brought in either as resources or as a cross-subsidy. When I say cross-subsidy, I'll explain to you what that means. I don't know how many of you are aware. Any company that sells MRI in India actually loses money. I don't even know whether you're aware of this. But how do you think they're selling MRI? Actually, they lose money. They lose money by selling MRI. The reason is they usually have a basket of products. Ultrasound, they make money. CT, they've started to make money. As a result of that, they're able to sell MRI at such an affordable price, right, that you're getting MRI at 5,000 rupees, even if you're doing it at a private, government, of course, subsidizes it. And how does that happen is because there is a market ecosystem. When I say market, I'm not talking about money. When I say market, your problem has to become other people's problems in a positive sense. Right? What I meant is, there is value, and that is when you will have an economy built around this situation. Right? So these are the numbers, and I wanted to give you parallels to the thing. So my summation, and I'm not driving a personal agenda or anything, is you want driven entrepreneurs who are smart, wanting to, if not, desperate to get into this area, make this area attractive enough, like what happened in telecom, like what happened in the larger fintech, like the larger digital-based X services, that X you can fill with anything. And even in medical devices. By the way, you'll be very surprised. Medical devices is not in a very healthy state. It's not too different from assistive technology. Right? Better, right? But we're still importing 80 to 90% of, so you're importing 100%, we are importing 80%. I mean, there's not too much difference. Right? So I will stop there, we'll come back. Right?
Mohammed Ashil. This one, take this one.
Yeah, thank you very much. Thank you, Arman. And taking forward from the panelist here, so when it comes to affordability and the governance in that, it primarily boils down to basically our three dimensions of the universal health coverage. So we need to identify who all are covered, what all are covered, and how much is covered. So when we talk about who all are covered, person with disability forms a subset of the overall requirement, as Arman has rightly put it. So it forms a subset of the overall requirement of the assistive technology. For example, Niraju sir's team, and I was fortunate to be part of that. Niti Aayog is currently working on a strategic framework. It has gone through a lot of series of discussions on that, and it's finally coming out. So at that, one thing it is mentioned is that there are it is estimated that 350 million, at least 350 million, that is 35 crore people require assistive technology in India. And majority of them are older population. And if you see this population is the people who may be requiring assistive technology as of now, and the unmet need among them is somewhere around 50, that depends upon which item we are speaking about, but still it's more than 50% in almost all cases. So now we know that who are the people to be catered. Now comes the next question of what all will be covered. That's another major important issue. When it comes to assistive technology, it can vary from a walking stick to an exoskeleton. So the cost and the requirement and the technology involved in that varies a lot. So how do we define what is required and how do we actually know that which are the most important products? That's why ICMR, Government of India has taken the initiative, and WHO earlier has developed an APL and the assistive product list, and the global report on assistive technology, which we are speaking about, and the APL was developed by that person sitting there, Chapal Kasnavi sir. He's the person behind that. He was heading assistive technology in WHO HQ. So, having said that, so when we know that these are the basic set of assistive products, then ICMR currently came out with a list of NLEAP, that is National List of Essential Assistive Products. That can be taken as a basic thing. I'm sure that when I say that, I can see Arman actually responding to it. But when we say that NLEAP is a beginning, which we need to actually, there could be iteration, there could be modifications later also. But when we know that these are the basic essential products which the government intends to provide and ensure that everyone is having access to that. And taking from a single more step or a major step ahead in that, now Niti Aayog is working on making basic assistive technology, like 6 assistive products have been identified, like wheelchair, walker, then a walking stick, then spectacles, then and a hearing aid. These to be made available for every person in irrespective of their ability to pay. So the second part of the second dimension of the universal health coverage, that is what all are covered. That is being taken. I will get into more details in further discussion. And then the third part would be the most important thing, and that actually comes with the affordability part, is how and what is the range of coverage. Like for example, when we say that we need to give assistive products, we need to provide the assistive technology, where does the money come? And as rightly put in, like there are many things which actually actually determines that. That include the scale of items. Like for example, if you have to manufacture something in low cost, the scale should be, invariably the scale should be higher to make it feasible for the entrepreneur to start with. So how do we make sure that there is a market volume, identified market volume? And can anyone guess the level of market volume for this 21 assistive technology which was assessed as part of Niti Aayog's work? Is that it comes around 82,000 crores. Just these 21 assistive products, if you look at the market based on the perception of their need, that's around 82,000 crores. And a majority of that is an unmet market. And you have a kind of an area wherein which the entrepreneurs can come in, the private market can come in, and they can make the money. But the policy ecosystem and everything need to be in that. That's a major work which is going on. So now, when we say that how much coverage, then another thing also comes, whether it is covered under insurance, the supporting system currently available in the country, whether it is covered under the Ayushman Bharat, the assurance schemes which is available. There is a parallel, another work which is going on to understand these nuances and make these assistive products part of our regular healthcare financial support system. So there are various angles to be addressed. I will stop here as a beginning. Thank you.
Mr. Khanna, you want to add to your part, because I think EDIP is something which is a pioneer step from the government of India, and it's every nook and corner and everybody knows about it. So you wanted to share your experience or thoughts on what changes.
Thank you so much, sir. Thank you so much. I'll just continue with what Meenakshi madam said. EDIP is a bigger assistive devices providing program in whole of India. It started from 1980s. It is there. Why I would like to make an emphasis here from the government side is one is we have more than 3 crore population of person with disabilities, at least the minimum, in length and breadth of India. So it is, when you compare with the population of the world, barring first 50 countries, the population of all other countries in the world is less than 3 crores. That means the population of persons with disabilities is much higher So government needs to cater and make assistive technology affordable to everyone. So one major program which is here is the ADIP, which is actually evolving also, because recently they have given the price limit or income limit of 22,500 rupees per month. People can get aids and appliances free of cost. And if their salary is less than 30,000 rupees, from 22,000 to 30,000, you will be able to get with 50% subsidy. It's for everyone. Because at the field level, what we could see is people who are not able to get access for any kind of aids and appliances, this is a lifesaver for them. There are pros and cons of it, much could be deliberated here. But people who are not able to get any assistive devices, ADIP scheme is the one which you are able to get aids and appliances. And it's also evolving, because for VI, we have started giving tablets, smartphones, which is available in the commercial market. The commercial appliances is being given for them for the assistive purposes, which will be able to enhance their quality of life. Same way for hearing impairment, there was not only the BT hearing aids, but also for the learning purposes, there is a proposal that we'll be giving them softwares and tablets, which will be enhancing their learning capabilities. And a set of teaching learning materials has also been evolved under ADIP scheme. Earlier, we were giving only for the mentally retarded. That is, the new term is intellectual disabilities. But now, separate teaching learning materials has also been evolved for cerebral palsy, deaf, blind, so on and so forth. So, what I would like to impress upon is, this is the biggest aids and appliances providing scheme in Government of India. Even though, as Madam said, the funding may be it's again a part to be deliberated. But at least we are able to reach the ground level, make assistive technology affordable for the length and breadth of the country. Thank you. Thanks for the opportunity.
Thank you so much, Mr. Khanna. I think we have the Guinness Book of World Record in India, no, of distributing highest number of aids and appliances in 1 hour. Yeah. You know, I think, Meenakshi, you have your thoughts. You know, I think this is interesting. You know, from last 3-4 years, there is a lot of noise around AT in India, or 5 years rather. I will take the COVID years out. A lot of noise, and you hear about AT and disabled people everywhere. You find it mentioned in almost every document. And the Caesars of AT are sitting in this room. You know who. And no, it's very interesting, you know, and one of when Akila asked me to moderate this session, I told Akila, why me? Because I have so much to say myself. And this is a scam, how you want to stop people to say so much. You know, you stop, yes. So, you know, and these questions, you know, I also want so many questions. But again, you know, who are the people we're asking these questions to, you know? So, what comes to your mind when you look at AT? You know, you look at it as a social welfare scheme. It's a charity-driven scheme. Okay, you want to donate, wheelchair, distribute, and I think if you and let's call spade a spade today. If you want to get some CSR funding and you say we are distributing wheelchairs or any other, it's easier than you talk about other issues. You know, it's kind of, you have a beneficiary model. It works. It works. You can monitor it. How many bought? How many distributed? Beneficiary. One, my question again to all of you. You know, this cannot be sustainable, and I agree what Sir said. You know, that there has to be a ecosystem of entrepreneurs. You create a market, and when you create a market for these kind of products and services, quality will go up on its own. Now, I am also taking the liberty, because I am the moderator, to ask that also, you know, Meenakshi, to your point, and Ashil, there's something called a choice. They cannot, you know, if you look at, I think an AT, you cannot have one size fit all, right? There's something called choice, and all of us are different and have different needs. So how far are we from making that choice? You know, that if I need a particular wheelchair, I should contact somebody and say, this is my need, and you send it to me in a, you know, certain period of time. So what are your thoughts, Meenakshi? And yeah, you can take again my mic.
save some time and we can talk more. The bottom line is, who's the population that we are talking about? Understanding about the population that we are talking about, where we come from as people with disabilities. And so if you look at the income levels, I mean, the direct costs of families of persons with disabilities and persons with disabilities, using only the standard of living approach, we find at least 12 to 40%. Families of persons with disabilities incur 12 to 40% more to achieve the same standard of living as a family without a person with disability. It is not taking into account the goods and services required. It's very different. That is around 2 to 10 times more than the family income. That is what we require. So this tells us the gap between what can be afforded and what we are using, whether we are participating or not. And also, majority, more than 65% of people with disabilities are not working. They don't have an income. We cannot go by the family income. And most of the schemes, including the ADIP, is means tested and targeted. And we do not have data of people with disability to target it or means test it. So it's kind of a poverty targeted program, which will be a failure when it comes to persons with disabilities, where there is huge diversity and huge economic, including economic diversity, and there is a huge data gap. Okay? And the second issue is that needs assessment. When the assessment that we all go through to identify ourselves as persons with disability does not tell us what we need, what is our requirement, so that we can participate on an equal basis with others. Unless when we move away from this medical approach to a social approach of assessment of persons with disabilities, it is always like, I need it, I go and ask. If I have the capacity, I'll go to the market and buy. It is this level. And so it is always that 1 to 2% probably of the population whose family income can afford a certain kind of device will be able to afford, and they can participate in a certain kind of situation, not across situations of their life, right? From childhood to any age, basically. So this is the kind of population that we are talking about, and the core issue is the disability assessment and certification, which has to take a social approach. I'm not talking about ICF classification, but to take a social approach, which could be very expensive, but to take a social approach, like countries like Fiji has tried, countries like Indonesia is trying, Cambodia is trying. We could do that. At least to have a local level case management where it tells the community, it tells the government, like, what are the needs of people. And then moving away from a targeted approach, and then what is our social protection framework? Can an NSAP, which gives 300 rupees per month for more than persons with more than 80% impairment, can that serve the need? So what is our social protection framework? So should the cash transfer, which may be considered as an income compensation approach, but the services, which includes rehabilitation, habilitation, and assistive devices, has to come within the social protection framework in a country like us. I agree marketability, I agree quality, I agree everything, enterprise approach, but who is the buyer? The buyer can demand quality. I mean, you create an ecosystem like startups or whatever, in which everybody benefits. But at the end of it, the end user, what happens to that person? Will that person be able to participate in the current scenario, in the current environment? Do I even know that I can participate if my environment is accessible, if my mobility or personal devices are taken? Do I have that information? Who is driving that information to a person like me, who is sitting in some village or with the lot of intersectional issues? As a woman with disability, as a person coming from a Dalit community with disability, as a person living in a hill area with all these variations. I mean, so who should be the person who creates that enterprise, who creates this ecosystem, and what is it for the end user who is there, who is waiting to participate, and who lacks services, who experience barriers on a day-to-day basis by not being able to use the buses, transport system, local community services, hospitals, schools. I mean, what is it for the person who is systemically marginalized and whose economic condition is kind of, dependent on that 300 rupees monthly pension from the government, which most often supports the family and but not the person, because for the person it cannot support.
Sorry, what was the question? No. This is not Rohit Sharma's interview, but I truly wanted to just remind
No,
what the question.
again, if I change a little bit, there's so much of discussion and discourse around 80 in India all of a sudden. Taking cue from what Meenakshi is saying, what kind of an ecosystem is required? Like it just cannot be, an organization like IIT alone, or you have an 80 lab here. There are a few entrepreneurs who are making certain things. So, what kind of an ecosystem that's need to be created where you bring disabled people's organizations, civil society, or the government, private sector, venture capitalists? Yeah.
See, there are two numbers that came about. I don't know how whether you paid attention. It was giving a number which is potential, of course, it's slightly notional, of around 80,000 crores. And I don't think you priced it, extraordinarily, right? I mean, maybe it's 40,000 crores, maybe it is 30,000 crores. But the point is, it is a significant number, right? And anytime you see such a large amount, there are only two ways, or not only two ways, there are two ways largely such large numbers get. Either the government says, I will provide all this, which means the government needs to have 30,000 crores. There's no other way. There's no way to create an economy. Government cannot create an economy within itself. Or you form a certain policy and the government puts in a certain amount of money, then 60 to 70%, that number we can, that economy is created by the market, which is what happens in healthcare. You probably have not realized it. Right? Since Dr. Gandhi just walked in, I was actually just reflecting on something. Cataract. Today there are about 80 lakh surgeries that are done, 60 to 1 crore. Last year was quite high, 80 lakh cataract surgeries. If you look at the spread of that, you will actually realize it's very similar to the numbers you're talking about. 60% of that surgeries is done by the government, right? At some of the lowest prices you can think of. But do you know why the quality of the overall ecosystem, including the 60% and the 40%, all of them actually have a vision, which is, by the way, just to be aware, it is actually one of the leading causes of blindness. I'm not talking about a small portion of blindness. Why do you think it has happened? Because there is a market, because there is a quality, without compromising the 65%. In many of these cases, 65%, they're actually paying almost nothing. Okay? The 40%, which actually is around 25% of the overall population, 25 to 35% in terms of economic levels, has created an economic value chain so that a cataract lens can be as high as 35,000, even 50,000, right? What's the latest thing? 50,000, right? All the way to 500 to 700 rupees of the same quality. Then you have multiple players serving multiple segments of the market, right? And there is government. Right? This is the kind of example that you want to aspire towards. Since you asked an ecosystem question, I didn't want to give you a boring MBA type answer like, oh, you create this, this, and this. You just look at the cataract surgery market. Right? So you just do a basic multiplication, right? 1 crore surgeries being done. Average surgery cost, well, who pays for it? For a moment, let's just forget it. Right? Average surgery cost, all expenses put together, is around 10,000 rupees, 5,000 to 10,000, including travel. That's not a small market. Right? And that market actually is somewhat, there's a huge services market there. Here you're talking about only devices, but So never allow the government to design this ecosystem and have them budget this. Then the budget will be limited. Right? Even if it is 65% who are economically disadvantaged, which is the number which I estimated, right? The 35%, right, who have different varying levels of affordability, but they actually want high quality products, you let them participate in this value creation. Do not get yourself into a situation where the person who can afford is just importing because the person can afford, importing that 1 lakh or 2 lakh product, and the rest of them obviously will be stuck with the few hundred rupees to few thousand rupee product. Which, by the way, is what it was even in cataract surgery, several decades ago. People will either go abroad and get a cataract surgery done, or, you live with, a glass, literally a glass lens, which is literally, handmade. So that is one way to look at this ecosystem. Right? So you reflect on this number, so you will get your answers.
Yeah. I would like to actually take the classical example of the cataract surgery and a slight difference of opinion on the government role in that. If you see, when you say that government should never design, actually this program for cataract is designed by the government. It's the role of private entities is very important, but how the NPCB VI was done and how this 85 lakh surgeries for last year happened, that is a story which you must be knowing. I'll tell that. Like in 2021, the cataract surgeries came down like anything due to the COVID situation. So in 2022, I am looking at all disabilities, so I was also involved in actually designing the program on PM Netra Jyoti Abhiyan, which is actually led to this massive achievement of 85 lakh surgeries in last year. Our target was 75 lakhs, but we achieved 85 lakhs. And the role of private players was very much in that. As you said, around 60 in some places in Northeast is actually more than that. So how we did that? Because government designed that program in a way that allows the private, and also not to say allow, it actually increases or supports the role of private players. So what this 85 lakh surgeries once it's done, and there is something called for the spectacles they have kept 300 rupees as a capping also in that, so that there are, when the volume comes in that level, there are many companies which would come for this 85 lakh because there is a assured market and they can reduce the product cost because of the economy of scaling. So when we say that the role of government, as clearly put in, you cannot actually just depend on a kind of a camp model of or a charity model of provision. So there should be an intervention in which it should be the part of the healthcare delivery system. So like we have done for the pharmacy, India is known as the pharmacy of the third world, and also for many other second world, and it can be called as for developed countries also when it comes to vaccines and some medical devices also. So how was this achieved? Because the government intervention came in a way that it actually promotes the manufacturing of vaccines and all. That's why when Alimco, in the last 1 year, if you see that level of investment that happens in Alimco from the government is actually taking it to the next level. But provision actually does not happen just by manufacturing. It needs to be inculcated to the existing healthcare delivery system. That is something now Niti Aayog is trying out in Jharkhand. So how we can actually make assistive technology and assistive care services, assistive device and services as part of the existing healthcare delivery system. So that if a person wants a wheelchair, he should not be waiting for the next camp to happen. Just like for the basic things, for basic basic healthcare, this should be part of that, and that should be the part of the basic healthcare delivery system. That at the rights-based approach, there can be difference of opinion on whether rights-based approach is enough. But rights-based approach not only ensures that government is providing, the government creates an ecosystem in which private players can also able to provide that. And when specifically coming to the wheelchair, this thing, and as Arman has put it clearly, that how the wheelchair provision should happen, for if you take as an example. So WHO has come out with the provisional guidelines for wheelchair, which actually says that select, fit, train, and follow up. Select is a choice which you need to make. You cannot actually take 100 or 1,000 wheelchairs and go there and distribute. We need to actually select on which wheelchair we get, depending upon our requirement, depending upon our daily activities, what all are involved, and maybe you require more than one wheelchair. If a sports person is having a sports activity, he requires another wheelchair for sports and another activity for his daily living. So now we have requested Sujata Madam to actually come out with a provisional guideline. The guidelines need to be adapted for Indian environment. We cannot take just a global thing and work out here. So we need to actually come out with a Indian adaptation of the wheelchair provision, putting in all the experience from India and the shared knowledge and also the best practices. So we are looking forward that initiative from IIT Chennai in that. So when we, so the Mike, to sum it up, the government has a typical role of designing the healthcare delivery system, in which the private players plays an important role by design and by not default. Thank you.
Yeah, but you have to wait for 3 years in EDIP. If you get one product, the next one is for 3 years. Yeah, I know. I think closing remark from you, Mr.
As Sir said, in ADIP it takes 3 years. But it's again, in the scheme, we need to provide aids and appliances for the entire length and breadth of the country for all the people with disabilities. So that is the requirement. So, but we, as Meenakshi Madam said, as long we don't have a data, but government is coming forward with the data. We have now started with the MIS scheme. So all the data is being digitalized and we will be able to know who are all people is getting this aids and appliances. This data is also coming up. And one more thing, as I just want to talk on the vicious cycle, because disability leading to poverty and poverty leading to disability. So with the help of AIC, the Sugamya Bharat Abhiyan, we are able to make buildings accessible. Assistive technology has come into play, giving education, making education accessible for a person with disabilities, at least at large, with Sarva Shiksha Abhiyan and other schemes, because aids and appliances also play a major role under Sarva Shiksha Abhiyan scheme, where children are able to educate under remedial education system, special education system, inclusive education system. So once education comes into play, next their job and vocational prospects moves across, so they become a productive citizen. We will be able to contribute to the GDP of the country, because that was a study, but ILO and the World Trade Organization, I think Meenakshi Madam will also accept that in case a person with disability has been properly included in the system, the GDP maybe of the country will be improved to 5 to 8%. What is the existing level? So government is trying in all the aspects in providing an ecosystem that is barrier-free for person with disabilities, providing aids and appliances for the education purposes, giving assistive devices under ADIP scheme, under NLEAP scheme, under Ministry of Health, and so on and so forth, so that we could mainstream person with disabilities into the environment, the regular socio-cultural environment. That's what the government's aspect is all about. Maybe it is taken up in a very small way, but it will be moving progressively. That's what, from the government side, we thought we should bring it to as a submission.
Thank you so much. I think I have overshot my time by 10 minutes.